Okay, so I did get to use my backup case, and we'll just present it very quickly. So this is a 42-year-old gentleman that I follow. He has a familial TTR cardiac amyloidosis. So he actually has polyneuropathy and has been followed for some time. The diagnosis goes back to 2010, and it was actually part of the Endeavor study in Boston. He has a known rare genetic mutation. And I've been following him for the last year and a half, 2 years, and his LV function has declined. He's an EF of 35%. His last echo demonstrating marked biventricular hypertrophy, severe diastolic dysfunction was reported, and biatrial enlargement. So he's fairly symptomatic. He's only 42. With TTR amyloid, we're actually starting to work him up for potential heart-liver transplantation. This is his echo, as you see, so it does show classic features of amyloid, although the LV function is reduced. Notice there's biatrial enlargement as well as LV and septal and posterior wall hypertrophy. Now, you may look at the tissue Doppler very quickly and think that there's evidence of severe diastolic dysfunction or restrictive filling, but I would like to point out to you that the patient is in sinus rhythm and there is no A wave whatsoever. So this phenomenon is atrial arrest in cardiac amyloidosis. So I was following him, he was starting to get fairly symptomatic, developing NYHA class 3 dyspnea, and I was starting to look into options for treatment of his amyloid. Suddenly out of the blue, he was involved in a motor vehicle accident with an altered level of consciousness. He was found to have right-sided weakness and a left MCA territory infarction. He underwent successful endovascular treatment with mechanical thrombectomy. This is his infarction. You can see it's pretty obvious there. And he had a nice clinical recovery from this, so he didn't have any significant residual motor deficits. So in terms of working up his stroke, from the initial insult and the initial injury in the mechanical thrombectomy, he was in hospital for about 12 days. And his ECG demonstrated sinus rhythm with telemetry throughout the hospitalization demonstrating sinus rhythm aside from a few rare PACs, occasional atrial ectopy. So he undergoes standard neurological workup, which is order every test known to man, imaging of the head, neck, lower limb vasculature. There's no source of embolism. They do a TTE, they find a PFO, and they're convinced that this is the cause of his MCA territory stroke, even though there's no evidence of DVT on ultrasound imaging. So the question is, what would you do next? This is a young man with a rare entity who now presents with stroke. So him being my patient, me being a heart failure physician as well as an echocardiographer, did the next test that was the only proper test, left atrial strain analysis. And you can see that his peak left atrial strain is significantly reduced at 7.7%. But I pushed and pushed for a transesophageal echocardiogram, which usually it's the neurologist pushing for it. They didn't think it was necessary and they discharged him. So I brought him in as an outpatient 4 days after his discharge from hospital, and here's his transthoracic echocardiogram. So you can see that this is his left atrial appendage, and you can see here there's significant smoke and there's a fairly sizable left atrial appendage thrombus. Here we're looking at it from the back just because we can, and we see that thrombus on 3D. And you notice that in sinus rhythm, he has markedly reduced left atrial appendage emptying velocities. So upon seeing this in his fresh stroke, I immediately anticoagulated him with a NOAC. Not having experience in amyloid and stroke, I then elected to repeat the TEE about 6 weeks later. And here's what you see. Once again, he received 6 weeks of full dose of Pixaban. He was brought back for TEE, and you can see that the left atrial appendage clot has barely gone. And recall that this patient has not had one blip of atrial fibrillation. 12 days of monitoring, 8 years in a trial in Boston, multiple ECGs, not one iota of atrial fibrillation. So upon seeing this finding, I changed him to warfarin. I involved my colleagues in clinical pharmacology who are very good at ordering tests and basically managing warfarin. And you can see here, and it made me think a little bit about atrial mechanical dysfunction and cardiac amyloidosis. So this is a paper from 2007 showing that depending on the amyloid type, the presence of LV diastolic dysfunction, and the heart rate, you put in all three of these factors, the area under the curve is 0.87. So this is specificity and sensitivity for predicting thromboembolism in patients with cardiac amyloid based on the type. The stroke risk in cardiac amyloidosis, so atrial arrhythmias are significantly, are we don't know a lot about the true incidence of atrial fibrillation, but atrial dysrhythmias, we know, are becoming more and more prevalent in patients with cardiac amyloidosis, whether it's primary AL amyloidosis or TTR amyloid that we're seeing a lot more of. And oftentimes, the atrial mechanical dysfunction, as this paper elegantly, as Dr. Jory would say, showed, you can see that there are reductions in almost all atrial mechanical markers of function from strain to tissue Doppler parameters. And often as this patient had LV dysfunction, often the atrial dysfunction will follow the left ventricular dysfunction. So interesting paper on this from Jack in 2009, looking at patients with cardiac amyloidosis that were sent for DC cardioversion of atrial arrhythmias. So a good proportion of these are atrial fibrillation. And the pie chart below is most telling. So these are patients who underwent who were sent for DC cardioversion and it was not performed because 81% of them had significant thrombus. And a high percentage of them did not get classic dissolution of their thrombus with standard anticoagulation. Most of these patients also have spontaneous echocardiogram contrast, SEC as we call it, as well as decreased left atrial appendage emptying velocities. So I think this case highlights a couple of different learning points. First of all, it's very challenging in this patient with an absence of documented atrial arrhythmia in actually predicting his stroke risk. And I don't know what it was that made me want to get this TE, but I am certainly glad I did because we could have been missing a huge pathology that was under our nose. It was not the PFO that had caused it, that may have lended itself to recurrent emboli. These patients have an angiopathy risk. This patient did not have cardiac amyloid angiopathy. And the other question is which anticoagulation? When we have rare diseases like hypertrophic cardiomyopathy, when we have mitral stenosis and atrial fibrillation, standard NOACs we don't use. We typically tend to go with our old workhorse of warfarin. So I think that this case definitely nicely illustrates the atrial mechanical dysfunction that I feel gave rise to his left atrial appendage thrombus and his subsequent stroke, which he had a favorable outcome from. If you have patients with amyloid that do present with stroke, to have a low threshold for doing a TEE as part of the workup. As part of the acknowledgement, I'd just like to thank Dr. Usha Manian, our cardiology fellow, and also concurrent trainee CSE board member, and thank you very much for staying this late. Yes.